Hi guys, this is Jody, and this is your presentation on the ATI Farm Made Easy modules for pain, inflammation, and infection. So this is for both weeks 12 and 13, and this content will be on exam 5. So what we're going to talk about are medications to treat pain, and you should be familiar with some of these medications. At first, we're going to talk about the non-steroidal anti-inflammatory drugs, ibuprofen and aspirin. I'm sure you guys are very familiar with these medications as they are sold over the counter and many people keep them in their cupboards. Because they are non-steroidal anti-inflammatory drugs, as you can imagine, they reduce inflammation. So they're very helpful if the pain is due to inflammation to treat that pain. These medications also reduce fever. They are used for mild to moderate pain, so they really are not going to be effective if you are in that moderate to severe range. So mostly what people are taking these for is muscle aches. It could be symptoms related to cold, flu, that type of thing. Now, the ibuprofen and other medications other than aspirin that we talk about that are in this non-steroidal anti-inflammatory drug class actually can cause some thromboembolism, okay? So that would put a person at risk for clots. Aspirin, however, kind of stands alone and doesn't do that. Aspirin has this, it inhibits platelet aggregation. So if you know in the blood, if a person has a lot of platelets floating around and they stick together, those platelets can actually form a clot. So you will see some individuals that take a daily aspirin because maybe they are at risk for heart attack or stroke, or they have some kind of clotting history, and they'll take a daily aspirin. And so they're not taking it for pain or inflammation, but they're taking it for that because it inhibits that platelet aggregation. Aspirin stands alone in that, okay? Because other non-steroidal anti-inflammatory drugs like ibuprofen, and we're going to talk about a second generation one on the next slide, actually put a patient more at risk for clotting and heart attacks. We have to be very aware of that, okay? Another thing that you really need to be aware of is that you should not be giving NSAIDs to a person under 19 years old if they have a viral infection. So it's those two things together. If they're under 19 and they have an active viral infection. Because if you give a non-steroidal anti-inflammatory drug to a young patient, you can actually put them at risk for Reye syndrome, which is swelling of their liver and brain. So acetaminophen would be a better choice for a young person, okay? They can, although, take aspirin and ibuprofen for pain if they don't have a viral infection. So just be aware of that. So if you are giving this to a patient, assess their pain, watch for bleeding. They're at a higher risk for bleeding with these medications. These medications can cause some pretty significant GI upset, so I would instruct the person to take it with food. If they are taking it long term, like say you have somebody who has chronic arthritis pain and so they take ibuprofen every day, we would want to watch their kidney function. But for most people that are just taking this very occasionally, over the counter for headache or something like that, we wouldn't, draw labs or anything like that, okay? It would just be somebody who's on it long term. Again, there is thromboembolism risk with some NSAIDs. Not with aspirin. Aspirin actually helps prevent blood clots, but on the other side of it, the other ones can actually put people at risk for blood clots. And then most of the times these medications are enteric-coated. If they are enteric-coated, the patient should be swallowing it whole and not chewing the medication or cutting it, anything like that. A second generation NSAID is Selexipag. This is Celebrex. Some of you may be familiar with this one. Again, same thing with the other non-steroidal anti-inflammatories. It can upset the stomach, so they should take with food and watch for GI bleeding. Because this one has that thromboembolism risk, a patient may take aspirin along with the Celebrex to prevent or minimize that myocardial infarction or that cerebral vascular accident, so that's heart attack or stroke, risk. Okay, but if they're taking aspirin and Celebrex together, then we definitely have to be very, very cautious and watch for bleeding. We also want to watch the kidney function with that as well. Then we'll talk about Tylenol. This is your non-opioid analgesic, non-opioid pain reliever, essentially. This is acetaminophen or Tylenol. I'm sure you guys are very familiar with this one. Patients can take it for pain or fever reduction. It is over the counter. The biggest things that I see with this medication when I'm looking at questions is the dosing. A person should take no more than 4,000 milligrams a day. Somebody can overdose on Tylenol. It can be very toxic to the liver. So you want to make sure that they're not exceeding the 4,000 milligrams. Now, this is something to be aware of, that patients purchase these medications over the counter. If they have a cold or a flu or something where they're taking a cold and flu medication on top of plain Tylenol, they want to make sure that the cold and flu medication does not have Tylenol in it, or if it does, that they're really watching the dosages, because you don't want to go over that 4,000 milligrams. That really does put your liver at risk. Alcohol is going to increase the risk to the liver. So if a person has a pretty significant history of liver disease, or if they're a heavy drinker, this is not a medication you would want to be giving them. A dual mechanism analgesic, this is going to work multiple ways to reduce the pain, is tramadol. This is for more moderate to severe pain. It's extended release, so you want them to swallow it whole, and it's going to take longer to kick in because it's that extended release. So it'll take at least 1 hour to work. It can cause some sedation. You can use opioid agonists for respiratory depression. This is going to be prescribed, okay, not something somebody can purchase over the counter. Because it's dual mechanism, it means it has some of the opioid properties, and therefore we have to watch for tolerance, okay? And we want to make sure we were watching for that respiratory depression as well. So tolerance means that the patient is going to require a higher and higher dose in order to get the beneficial effects of the medication. And then we have the opioid analgesic morphine. There's a lot of opioid analgesics out there. There's fentanyl, there is Dilaudid. There are a lot of opioid analgesics out there, but we're going to talk about morphine. And when you talk about opioid medications, you should always have a Narcan available. So we have opioid, and then we have the reversal of the opioids, which is the Narcan, okay? The biggest things with your opioids is watching for respiratory depression. It's going to have some sedative effects, and so patients should not be doing anything that they need to be alert for, like driving, okay? And then when it's newly prescribed to a patient, really anybody who has an opioid at home that they're using, they should have the Narcan available for reversal of the opioid effects. So we will talk about the naloxone. This is the Narcan, okay? So it is this, okay, that we're talking about here, the naloxone. This is an antidote for an opioid overdose. So I was actually in clinical with students a couple of years ago, and we had a patient on this unit, and luckily it wasn't a patient that a student was taking care of, because it was a very, very unfortunate situation. And even though the students were not personally involved with this patient, they were very much affected by what had happened. But this was a patient who was known to use IV drugs. She had a very significant IV drug use history, and because of her IV drug use, she ended up with endocarditis, which was an infection in her heart. So she had this endocarditis, and she needed long-term IV antibiotics. And nobody would take her in home care. Nobody would take her in an assisted living facility, because she had such a high risk for IV, drug use, and she needed to have a PICC line in order to receive her IV antibiotics long term. So she basically was staying in the hospital as somebody just getting IV antibiotics. So she wasn't a patient that was checked on very often. It was just once a shift, once every 8 hours. They would go in and check on her, but she was like this alternate level of care, because she no longer met the acute reasons to be in the hospital. She was simply there for long-term IV antibiotics. Well, somebody must have brought her in some IV drugs, and she injected them through her PICC line that she had, and she was in the bathroom when she did this, and she overdosed. And it was something where, the patient in the bed next to her was requiring a lot of care. I think the patient in the bed next to her was having an MI, to be honest. I think that was going on. So we had a student involved with that patient, kind of involved with that process of going through the MI. And one of the caregivers or somebody who was at the bedside with this patient said, the other patient's been in the bathroom a really long time. And so they went to find this patient. Of course, she was down. She had overdosed. So they did go through and they Narcaned her twice. So gave her 2 doses of the naloxone to try and bring her back, but she had been down for too long. So this is something I used to carry Narcan with me when I was a community health nurse. And I would carry it in the community because I worked in areas where there was high drug use. So it is something to help with the opioid epidemic, because we know that we do have a problem in our society with opioids, and this Narcan can save a life if you have that. So it is going to reverse the effects of opioid. It is just opioids, okay? It's not going to reverse the effects of something that is a non-opioid. It can cause some hypertension, and it can also cause hypotension, and it can cause ventricular arrhythmias and nausea and vomiting. I think the biggest thing to note with the Narcan is that if you have somebody with a lot of opioids in their system, very often 1 dose of Narcan is not going to be enough, because once the Narcan wears off, they still have that opioid on board. So they may need multiple doses of Narcan. They really should be monitored in a hospital. And I had a student nurse tell me once that one of her family members had been Narcaned, had received Narcan in the field by a police officer or something like that, because they had overdosed, and they took them to the hospital, and this person checked themselves out against medical advice and very shortly after died of an overdose, not because they did more drugs, but because the amount of Narcan they got was not enough to overcome all of the opioid that was in their system. Okay, so the opioid outlasted the Narcan effects. Use can cause withdrawal in patients that are physically dependent on opioids. If we now are taking that opioid kind of out of their system, you want to look at their respiratory rate, monitor the blood pressure, level of consciousness. Really, if you're giving somebody Narcan, you want to watch that patient, to make sure that their respiratory is good, blood pressure is good, and then we want to make sure that they don't end up going into respiratory depression again once that Narcan wears off. Okay, so again, on the bottom there, effects of the opioid may outlast naloxone. And because of that, it's good to have that resuscitation equipment available. These 2 drugs you're not going to see very often. These are for moderate to severe pain, and they're really an adjunct to anesthesia. So if you worked in the perioperative setting, you may see these. But they're not used very often. They do increase cardiac workload. Okay, medication. And so these are medications for pain, and we do have some anti-inflammatories in here, but the one medication that we're going to talk about to treat inflammation is an anti-gout medication, which is allopurinol. If somebody is taking allopurinol, we want to encourage fluid intake to protect the kidneys from the increased uric acid secretion or excretion. Okay, dose adjustments of warfarin may need to be adjusted because this is going to impact or kind of interact with warfarin. Allopurinol can cause drowsiness and headache, and it can also cause some bone marrow depression. So if somebody is on this long term, we'd want to be looking at their CBC. Prednisone is a big one. You guys will see the glucocorticoids used for multiple reasons, and so this is a drug you guys should become very, very comfortable with. It's used for inflammatory and autoimmune disorders. It does suppress the immune system, so it is going to put that person at risk for infection. So we have seen this used for patients who are post-transplant, organ transplant, because they are at risk for rejection after transplant. So we actually use this medication to depress that immune system so that it's not rejecting the transplant. So you can actually see it given for that purpose. But so we want to watch for infections. It can cause some fluid and electrolyte imbalances. It draws calcium out of the bone. So if somebody is on this long term, they're at risk for osteoporosis. We can see Cushing's syndrome if somebody is on this, and we really do, if a person is on a glucocorticoid, we want to taper them off their dose to prevent Cushing's. So Cushing's syndrome is that, withdrawal of the cortisol. We can see like moon face and the buffalo hump on the shoulders. Those are signs of Cushing's syndrome. and it decreases the effects of insulin and hypoglycemic. So if you have a diabetic patient, their sugars can go really, really high when they are taking glucocorticoid medication. And we're going to jump right into infection here and talk about anti-infectives. So broad spectrum antibiotics are used if we don't know what the bacteria is. So what can happen is if you have a patient that comes into the hospital with an infection, we really want to treat them so that we don't put them at risk for sepsis, right? So if you have a patient that comes in, the very first thing you want to do for that patient if we suspect infection is to figure out where the infection is coming from. So let's say we think it's a urinary tract infection, then we're going to want to make sure that we get a urine culture. If we're not sure, we might get a blood culture to find out. Once the cultures are drawn or obtained, then you can start your broad spectrum antibiotic. And then once we get the results of what kind of bacteria is there, then we can narrow it down and give a better antibiotic. If you have somebody on a broad spectrum, there's more risk for antibiotic resistant bacteria. Okay. Again, we want to draw cultures before starting antibiotics. Patients should always complete their antibiotic therapy. So you know that if you have ever personally started an antibiotic for an infection, like sometimes you start to feel better within like 2 days, but you have maybe 1 or 2 weeks worth of antibiotic to take, whatever is prescribed. And a lot of patients will say, I feel better and I don't like the nausea and the effects of the antibiotic, so I stop. Well, the problem with that is if we don't kill off all the bacteria that lasts is the strongest strain of the bacteria. And then you can kind of get this rebound infection that is very, very significant and severe and hard to treat. So you want to make sure that patients are completing their course of antibiotic therapy unless they're having like a significant allergic reaction. Watch for C. diff. So C. diff is that chronic diarrhea because along with the bad bacteria, we kill off all the good bacteria with the antibiotics. So we would watch for C. diff. And then if giving IV, watch for drug compatibility because not every drug is compatible with normal saline, believe it or not. And some of them are not compatible with maybe other meds that you've been transfusing through somebody's IV line. So you really want to watch for compatibility because you could really cause harm to a patient if you put multiple medications through a line that are not compatible. Okay, you can actually crystallize that fluid in the IV tubing. Antibacterial is vancomycin. This is a big one. You want to administer over at least 60 minutes to avoid what used to be called red man syndrome. They don't call it that anymore. It's like a flushing syndrome, but you can see like this, all of this redness that you see over there. We want to prevent that. So it's called vancomycin flushing syndrome. And it can itch as well as be very, very red. It's also nephrotoxic and ototoxic. So nephrotoxicity, we want to watch their kidney function. Ototoxicity, it can impair their hearing. So I did know my daughter's friend when he was 7 was, oh my gosh, he had stage 4 glioblastoma. He is actually about to graduate from high school, which is just quite miraculous after all he went through with treatments. But he ended up having an infection and he was treated with vancomycin and he ended up losing some of his hearing. We want to watch drug levels, so the peak and trough. Remember, peak is the highest concentration of drug in the blood, so we're going to draw that very shortly after we start administering. It's going to be whenever that medication is expected to peak, and then that trough is the lowest level, so we draw the trough right before the next dose is due to be hung. And it can cause thrombophlebitis, so you want to watch their IV site. Okay, make sure that's patent. Tetracycline is an antibacterial that you might see. It used to be used a lot for acne. But you can still see tetracycline used. It can cause this, if somebody takes it when they're pregnant, it can actually discolor the teeth of the fetus. So it is something that, you would want to know if a person is pregnant, if they're taking this, because it can cause permanent damage to the fetus as far as their teeth. Pregnant women and children should not take It does affect the liver. There is hepatotoxicity, and it does decrease the effect of oral contraceptives. So if you have a woman of childbearing age who is taking tetracycline, you want to make sure they're using backup contraception. Then there is the anti-infective ciprofloxacin. This is a fluoroquinolone. I think that's how you say it. This can cause some dizziness and headache and confusion in older adults. It also causes sun sensitivity and puts person at more risk for burning out in the sun. So they want to avoid sunlight, make sure they're using hats and sunscreen and all that good stuff when they're out. It also puts somebody at risk for Achilles rupture. So this is something you'd want to be very aware of if you have an athlete taking this medication. It can increase warfarin levels. So if somebody is taking warfarin, which is Coumadin, they would need to have their levels checked more frequently and most likely have their dose adjusted. And it can also cause some hypoglycemia when taking with diabetic meds. So if you have a diabetic on this medication, you would want to be checking blood sugars more frequently. Then there's antimyobacterials used to treat tuberculosis, and you're going to learn more about these in semester 4. I believe somebody teaches TB in 4, but isoniazid can cause some liver damage and peripheral neuropathy. And so to prevent that peripheral neuropathy or manage the symptoms, they can give some B6. We also want to watch for drug compliance, because when somebody is on medications to treat TB, they are on a very long drug regimen, like over several months. Okay, and we want to make sure that we're killing off that TB, because we do not want outbreaks of TB in our society. So you want to make sure that they're compliant. And this can be hard. There's actually programs out there that will go see people who live in the streets and in shelters that are taking medications to treat TB. Because that's where you're going to really see TB outbreaks, is going to be like prisons and homeless shelters and stuff like that. So we definitely want to look at drug compliance for that long drug regimen. And then there's rifampin, and this is an adjunct therapy for tuberculosis. This causes all of the body fluids to turn like this reddish orange. And so you will see that, and it can stain somebody's contact lenses. So if, somebody's taking this, you want them to be aware of that. Probably best for them to wear glasses rather than contact lenses, because those can become very stained from those red-orange tears. We want to watch liver function, and it does decrease the effectiveness of oral contraceptives. So with anything that decreases the effectiveness of oral contraceptives, we want to make sure that a woman of childbearing age is using backup contraception. And then we have the antiviral acyclovir. This treats severe viral infections for those who are immunocompromised. We want to ensure IV patency, because it may cause tissue necrosis, and that's what you see over here. This was an IV site. And the IV site infiltrated and actually killed the tissue around where the IV site was. A topical may cause a skin reaction. We want to watch the kidney function because it can cause some renal toxicity. And we want to make sure that we're giving a lot of IV hydration after the patient receives acyclovir. And then lastly, there is amphotericin, which some people will call amphoterrible. This is a drug that is known to have a lot of side effects, okay? And so you see this over here, Amphoten, to tell you kind of all of the side effects that you might see from amphotericin B. And this was always one of those that I had a hard time administering to a patient, because I knew the patient was going to feel like really bad when I was giving this IV, because it does cause like a lot of side effects. And if I remember correctly from practice, this is something not compatible with normal saline, but I would have to look that up, and I wouldn't test you on that. But I remember there was something really unique with the amphotericin that we really had to be very cautious when we were administering it through the IV. Because it can make somebody feel pretty horrible when they're taking it, you can give some diphenhydramine and or Tylenol to kind of manage the symptoms. that they'll feel from the amphotericin. And they typically occur about 1 to 2 hours after the IV administration is started. A patient will get this fever, chills, headache, tachycardia, hypotension. And so, you're giving this to a sick patient, but it does make them feel just as sick, if not worse, when you're giving the medication. So it's very important that they get it, but there are some significant side effects that you can see. It is toxic. It can be toxic to the kidneys, so we want to watch for renal toxicity, means watching the kidney function test. It can also suppress the red blood cell count, so you want to watch their CBC. And it is one that I have given several times in practice, more than several times over the 25 years. But yeah, fungal infections, when you have severe fungal infections, you aren't seeing a ton. But when you do have to give this medication, it is one that you will remember giving. And that is it. If you have any questions, reach out. Otherwise, make sure that you have gone through ATI Farm Made Easy, both modules for the pain and inflammation and infection.